So once again, just good evening, Dr. Sir. Myself Satyajit Samal, sales manager with my colleague Mr. Niranjan Vishnu, introducing this webinar, sir. So say very good evening to all eminent doctors. Thank you so much for joining us for today's webinar. Our endeavor is to spread awareness about rabies, which is fatal but can be avoided once appropriately vaccinated. This is an initiative from Kadila through its innovation to serve the society and humankind. The topic of the webinar is dosage reduction strategy in rabies management role of novel vaccine. Dear Dr. Rabies is world's first novel 3-dose anti-rabies vaccine, and with great pride, we would like to inform you that Rabies has successfully completed 1 year of launch with more than 40,000 annual-wide victims being vaccinated. 100% compliance was recorded, and no case of adverse reaction was recorded. With this, it is my honor to introduce you to the speaker today's webinar, sir. Dr. Panigre, sir. So start the webinar, sir.
Thank you, Mr. Samal, for your nice introduction. So good evening to all friends. Today evening we will be discussing regarding a novel 3-dose G protein vaccine which has been found by Kadila, and we are proud of Kadila because this is the first time in the world a 3-dose vaccine has been invented by Kadila. And during the last 10 decade, also 10 to 12 years, Kadila is after this vaccine, and finally the Kadila became successful by coming out this 3G protein vaccine. So we'll be discussing what is that 3G protein vaccine today. Next. So as all of us know, as Mr. Samal has already told, so globally, rabies is a very common problem. And specifically in India, we face this rabies day in and day out. Almost 59,000 human deaths annually in the total world, and out of which 20,000 human deaths per year occurs from rabies in India itself. And 90% of these deaths are due to the dog bites. Okay. So these 20,000 human deaths that constitute of 60% of the rabies deaths in the Asia, and it also, that is a 35% globally, which is the death occurs in India due to rabies. So this is really very problematic in our country. So how can we prevent? We have got vaccines. Vaccines are there, but what are the loopholes of these vaccines? How this compliance is less? So now Kadila has come out a new vaccine for better compliance and better safety and better efficacy. Next. So the current management is, the current management of that is rabies. We are now dealing with prophylaxis, not treating rabies. We are dealing with prophylaxis of rabies, what we call the post-exposure prophylaxis. So what is that post-exposure prophylaxis? Because whenever a rabid animal bites, then what should we do? That is what we call the post-exposure prophylaxis. So the present post-exposure prophylaxis is, so let us take the proper wound treatment, then active immunization by rabies immunoglobulin, and the passive immunization by rabies immunoglobulin, and active immunization by the vaccine. So this is the strategy of management of post-exposure prophylaxis. So what this slide tells us, rabies post-exposure prophylaxis, what we do in our country, what is the real guideline is. So we have to give the vaccines 4 doses, especially what the CDC guidelines says, we have to go 4 doses, that is on 0, 3, 7, 14. Ordinarily, immune competent person the fifth dose is usually not necessary in an immune competent person, but people who are that is immune who are definitely immune deficient patients whom we suspect these people are really immune deficient. There we can give the fifth dose of vaccine, that is on 28th day. So this is the regarding the active immunization. Regarding the passive immunization, there are categorizations of it, but now the CDC, as per the CDC, they give to every patient that is rabies immunoglobulin. Whoever takes vaccine, they also gives rabies immunoglobulin. But because of the cost, and that is who tells regarding only, and that is who as per the who criteria, category 1, 2, 3. So in the category 1, who doesn't advocate rabies immunoglobulin, but in the category 2 and 3, who advocates rabies immunoglobulin. So rabies immunoglobulin, because the whole purpose of giving rabies immunoglobulin is because the vaccine takes at least some time for the antibody production, some time for the protection, and during that time, this rabies immunoglobulin will take over. So that because it has been seen also that before the vaccine acts, the rabies can occur. So that's why the rabies immunoglobulin is very important. So the CDC guidelines say everybody who takes vaccine should be given rabies immunoglobulin. But because of the cost, the availability, the cost, that's why that is the WHO guidelines is little different. That is in the category 2 and 3. So this is regarding the RIG, and this is regarding the vaccine and wound treatment. Wound treatment is very much necessary because there should be complete and there should be at least for 15 minutes the wound should be cleaned with soap and water. And also one can use pyridine iodine, that can be also used, but it should be thoroughly cleaned. And by that there are studies which say that there can be 90% clearance of the virus. But there are other studies, they don't agree with it. But whatever may be, we get the benefit if the wound cleaning is done very thoroughly. So these are the different strategies of management. So let us the next slide. Non-compliance. Not this challenge. What are the current challenges? Non-compliance is a major factor because what happens? Patient has to run. Patient has to go at least minimum 4 to 5 times for taking this vaccine. Again for the immunoglobulin. So now, of course, it is available in the government sector. So, but if somebody doesn't go to the government sector, he has to also pay from the pocket. So but the repeatedly going to the hospital, repeatedly going to the healthcare worker and taking the vaccine, that's why the compliance is definitely less. So non-compliance is a major challenge for this rabies vaccine. So current rabies vaccine are cell culture vaccines, and inactivated vaccines are more than 50 years old technology. So this is the inconsistent potency, stability, availability, adverse events. So we don't use these inactivated vaccines because that is in the earlier days that was being used, but now this inactivated vaccines is not being used. Now we are all using the cell culture vaccine, whether human blood vaccine or when we are giving that chick embryo vaccines, or also you can give in the Rabipur, that is the Bherura vaccines. So these are the different types of vaccines what we are using today. Next. So compliance and anti-rabies vaccine. So compliant, who received the full course of ARV, that is the scheduled doses of ARV on the recommended date. So that is what we call compliant. Compliant means somebody received the full course of ARV in the right time. Delayed compliant, who completed scheduled dose of ARV within 60 days but defeated from the scheduled regimen. The person complies within 60 days, but it's only within maximum within 28 days. But the patient takes to take the vaccine within 60 days. That is delayed compliance. So that frequently the patient deviates from the scheduled time. And dropout and non-compliant is who are taken at least one dose of ARV after annual bite but not completed all the scheduled doses. So that is what we call the non-compliant. This is the definition of compliant, non-compliant, delayed compliant. Next. So this slide shows rabies post-exposure prophylaxis in routine practice in view of the new Center for Disease Control and Prevention of, and also World Health Organization recommendations. So these are the various recommendations. That is the CDC guideline. This is the WHO guidelines. So both they say the limitation to 4 dose, 4 recommendations. So this specifically that means see as per the CDC and also who these 4 dose vaccines should be given. And in case of immune suppressed, you can go for a 5th dose. So all this says a retrospective analysis done at travel clinic. A total of 110 patients who received rabies 4 doses post-exposure prophylaxis. Shortcomings in the management of these patients were what they have found that late initiation of rabies PP in travelers, administration of human rabies immunoglobulin and antibody level less than 0.5 international unit per ml in 6 to 90 patients, that is 6.7% after 4 doses of vaccine. So this study, what that says means there are significant number of patients who start anti-rabies vaccine late because we should start immediately. So that is what I zero. That is the same day. But there are many patients, significant number of patients who start anti-rabies vaccine late, number one. Administration of that is human rabies immunoglobulin. There are two types of rabies immunoglobulin. What is one is the human rabies immunoglobulin, the other is the equine rabies immunoglobulin. So in the resource cons setup like India, we hardly use human rabies immunoglobulin. We frequently use equine rabies immunoglobulin. And there is antibody levels. How can you know? How can you know that this patient is protected? So you have to see that is antibody level. The antibody level should be more than zero point 0.5 international unit per ml. So, but they have seen in these patients almost 6 to 90 patients, that means almost 6.7% after 4 doses of vaccine, their antibody level is less than zero point 0.5. So, what to conclude? The conclusion is patients do not always receive optimal rabies post-exposure prophylaxis under real life conditions. That's why a significant proportion of patients did not develop adequate antibody levels after 4 doses of vaccine. Next. These are the 4 studies that has been found out. So non-compliance to 5 dose proven cause of. So what this uh, slide says, you see, and these are the 3 patients. Okay, these 3 patients shows one is a 58%, 58 years female, and she has sustained street dog bite, who was killed soon, and she got 3 doses purified dog embryo cell vaccine. That is what we call Rabipur. Okay, so you see the category that was category 3 at the right side of nose, right side of nose. So 20 days, that is presentation of she presented with after 20 days and presented with fever and 5 days of altered sensorium. So finally, what happens? Because of this non-compliance, she finally expired. Here is another patient lady, the gents, that the male, 38 years male. He also sustained bite and he took only 3 doses vaccine. And the first patient also took 3 doses vaccine, 037. This patient also took 3 doses vaccine, 037. He also finally died of encephalopathy. And the third patient, that is, he also had 34-year male. He also had street dog bite, and he also took 3 doses of vaccine 037, and he also finally died of encephalopathy. So what does it means? That means, sorry, Next, the previous slide. Yeah. So the reason of death may be due to lack of administration of rabies immunoglobulin or poor compliance. So this shows that means either there is a poor, the death were due to poor compliance or the death were due to lack of immunoglobulin. That is because what we have seen, all were in category 3. All the patients, all the dog bites were category 3, where rabies immunoglobulin is a must. That they should have been given rabies immunoglobulin. Number one. Number two, they took only 3 doses. So either of the two or both of the two could have contributed to their death. Next, next slide, please. Yeah. So this is an original article regarding the compliance to post-exposure prophylaxis among animal bite patients. This is a hospital-based epidemiological study. This was done at Safdarjung Hospital, New Delhi, and almost they have taken 360 animal bites patients, and this is a pre-diagnosed, pre-tested, structured questionnaire was administered by the interview taken. So what they have found, you see, 46% of patients only they were compliant, whereas 48% were the sorry 48% were compliant, where 46% of the patients they were non-compliant, and 6% were delayed compliant. Already we have seen that what is the definition of compliant, delayed compliant. We have already seen. So finally, they have found 53% were non-compliant to the full course of ARV. So we see in our own study, in our study from India at Safdarjung Hospital, what they have found 53 means half of the patients were non-compliant. So this is a very, very significant data. If patients are not compliant, then definitely the death rate is high due to rabies. Next. This is a brief another research article. Compliance to anti-rabies vaccination in post-exposure prophylaxis. This is this study. So this what this study shows. This study shows at Municipal Corporation Hospitals, Bangalore, and again here are 215 animal bites patient. 1 dose of rabies vaccine administered intramuscularly on day 0, 3, 7, and 28 as PP. Also measures constraint for compliance to complete course. So you see the compliance rate for intramuscular rabies vaccine was only 60%. The compliance rate was a day to day, it is only 60%. So the same thing, it is almost same as the Safdarjung study that which we are seeing, that is also 53%. Next, next slide. So what are the constraints? What are the constraints for the compliance in complete course of anti vaccine? So you see, now this study shows that this is published in Journal of Public Health. This study shows that is the factors. What are the factors really that influence this non-compliance? That is loss of wages. Loss of wages because out of the 20,000 deaths it has been seen, most of the deaths are in the rural areas. Most of the deaths are in the rural areas. And this is study shows that loss of wages, that is 47% is non-compliance factor is due to loss of wages. And what are the other factors? That is interference with school timing 11%, distance of the hospital 11%, cost incurred is 13%, and forgotten date is 18%. So these are the major constraints for compliance to complete ARV in our country. Next. Next slide, please. Yeah. So this is one slide that shows the evolution of rabies vaccine. Already you have seen that starting from 1885 to now today, that is inactivated vaccine of the nervous tissue brain that found in the 1911, and in the first one 1885 that was live attenuated vaccine. So gradually now cell culture vaccine started in 1976. So we are using now cell culture vaccine, and also now we have gone to the stage of recombinant DNA vaccine. So these are the various improvements in the that is the history of rabies vaccine globally as well as in India. Next, so now, so these are the novel. So how to face the challenges? How to skip over these challenges? So now, friends, this is one straightforward solution which Cadila has come out. That is the novel three-dose recombinant rabies G protein vaccine. So this is the rabies 3. So they have come out with this vaccine, the recombinant vaccine, that is at least if you give 3 doses, that means if the dosing amount is shortened, then at least the compliance will be better. So this is the novel 3-dose recombinant G protein vaccine. As you know, the rabies virus contains 5 genes. The rabies virus contains 5 genes, out of which the G gene that constitutes the G protein. So this is what they have Cardilla found out to have recombinant technique, and that they have produced from that the recombinant rabies G protein vaccine. So this is the first vaccine in the world with 3 doses of intramuscular injection, that is on day 0, day 3, and day 7. And so there is a better compliance due to easy to flow regimen and less visits. So easy to flow means they are also we do not give the vials. So these are also pre-filled syringes. So you have to easily give, also easily administer. And convenience, definitely ready to use, no reconstitution because of pre-filled. So no reconstitution is required. And this is the first protein subunit vaccine in the world. And this is the prepared by one VLP platform technology. And this vaccine, because of its efficacy, safety, and also that is a less dosing, hardly in within 1 week, all the doses are finished. That means the patient is free after only 1 week, only 7 days. So that's a definitely it's a great intervention by the Cadila. So this G protein vaccine is now available in India. Next. So this is regarding that BLP technology. What that's in BLP is virus-like particle, that is technology. So VLP are protein complexes exist in nanoparticles. So G protein is difficult to stabilize. G protein isolation using VLP technology purified and stabilized by cardiac pharmaceuticals. So from the naive virus, and VLs are similar naive virus particles, but that do not contain the viral genome. So they cannot, because this is a recombinant technology. It's not that viral protein is not there, but it's a recombinant technology. They have found the G protein like particles. They cannot replicate but can mimic the viral antigenically without being pathogenic. So they are capable of inducing a strong humoral and cellular immune response. So that's the what this BLP as vaccines. Next. So they have already done the clinical phase 3 trial. So this is the study design. So 0 to 3 doses and 037 doses, 303, that is the 0377, sorry, 3 doses. So what have found? Now, that is they are compared with Rabipur, which has given 5 doses. So they are compared with Rabipur, and what they have found, this is the phase 2 data of novel rabies vaccine, and they have found in no way this is inferior to Rabipur. We know Rabipur is very, very effective. So efficacy-wise, at the J270, so this vaccine is found to be non-inferior to Rabipur. Next. So this is the clinical study phase 3. So this is safety and immunogenicity of novel 3-dose recombinant nanoparticle rabies G protein vaccine administered as simulated post-exposure immunization. This is a randomized comparator-controlled multicenter phase 3 clinical study. Here, next, yeah. So this vaccine, almost they have taken 533 subjects. Okay, so they are compared 037 regime with the regime of 037, 14 and 28 regime. So in this group they have taken 533 subjects, and in the 5-dose regime they have taken 267 patients. So to evaluate immunogenicity and safety of rabies protein were vaccine administered as a simulated post-exposure immunization in healthy volunteers. So again, they have taken this a randomized comparative controlled multicentric study, total 800 patients. So the randomization is 2:1, as I have shown, 533 against 267. This is called a Travis vaccine. This vaccine is known as the Travis vaccine. This THRV, that is the Travis vaccine. Next. So here is the result. This is the efficacy, because whenever we bring out a new molecule, it must prove its efficacy. Not only efficacy, it must prove its safety. Okay. So efficacy wise, you see the seroprotection is almost at par. Okay. It is almost the Travis vaccine and the reference vaccine. You see, almost it is at par. So the results were consistent across different age groups and genders, and the observed difference was 15.2 percent, with the pre-specific region minus 4%. So non-inferiority for seroprotection primary endpoint day 14 and 42 were made, and test and comparator are identical in seroprotection rate both on days 40 and 42. And the adverse events, the local or systemic adverse event, were definitely in the 3-dose vaccine, they has got a better safety profile. You can see from the graphs, the safety profile of the 3-dose vaccine is better, because you see this is the gray, uh, yeah, this is the gray graph. You see here in all the on the both sides, you see the reference vaccine has got more this adverse event than our Travis. So that's why Travis safety wise also Travis is better than the comparator, and efficacy wise it is non-inferior. So in the that is stage 3 study, it has been proved that the efficacy wise it is non-inferior with the comparator, and the adverse events are also much less against the comparator. Next. So the study conclusion was the novel 3-dose was non-inferior to the reference vaccine, less adverse effects compared to the reference vaccine, and novel 3-dose was also found to be safe and immunogenic, and is comparable to 5 doses of who pre-qualified vaccine. That is what we want. We want that the efficacy should be good, and also there should be less of the adverse events. That has been proved in the phase 3 clinical trial of this vaccine, what we call the Travis vaccine. That is a 3-dose vaccine, a G protein vaccine, and it is a really novel idea of Cadila, and it is the first time in the world we have got this vaccine, and it is now found in the our country. Thank you. So Cadila has been awarded this Golden Globe Tigers Award Malaysia for this innovative product of the year for this vaccine. You see, so this is also it has got also the Pharma Innovation of the Year by the Economic Times. Naturally, we are proud of Kadila because certain innovative idea and innovative vaccine they have brought out in the world for the first time. Okay, thank you, friend.
Thank you, sir.
Thank you so much, Doctor.
Thank you very much, sir.
Thank you so much, sir, for our informative talk, sir. We truly appreciate your efforts, sir. Last but not the least, as already you have mentioned, that Thabis has won the 2 prestigious awards in innovation category, Pharma ET Award, ET Pharma India Award, and Golden Globe Tire Award. Thank you for your valuable time. Very soon we'll meet and discuss regarding more about this Thabis. Anything you want to add,
Okay.
Mr. Niranjan?
Thank you, sir. Thank you very much, sir. Sir, already 68 participants is there, sir. I'm watching.
Okay.
You watch live, sir. You know,
Okay.
entire Odisha doctor
Okay.
was there, sir. Thank you, sir.
Okay.
Thank you very much.